Hello, and thank you for taking the time to learn about Grafton Integrated Health Network and Ukeru Systems, a long-standing specialty care program with locations in Northern Virginia and the Richmond region. My name is Scott Zeiter, and I'm the Chief Operating Officer for Strategic Business Development. I'm delighted to introduce you to a company that captivated me back in 2011 and continues to innovate and grow to meet the ever-changing needs of the complex population we serve. Grafton's approach is person-centered, trauma-informed, and data-driven, with each plan of care as unique as the individual it serves. Our philosophy is one of comfort versus control, helping clients thrive in the least restrictive environment consistent with achieving the best outcome. In addition, we seek to achieve the greatest impact during the shortest possible length of stay for each client we serve. When you think of therapeutic approaches that are commonly used throughout the field of behavioral health care, how many can you name that consider it to be a failure on the treatment team's part if the client doesn't make progress? How many truly consider the why versus the how the client must change to meet our notions of typical behavior? From its beginning 60 years ago, Grafton has been committed to drilling down as deeply as necessary to get to the root of the why. It is our responsibility to figure out why they are struggling and to teach the skills necessary for success. All staff are trained to be behavior detectives. As with many not-for-profit provider organizations, Grafton was the lifetime mission of our founder, Mrs. Ruth Birch. Mrs. Birch believed that kids with disabilities responded best to services tailored for their specific affinities and interests. Her own son, for example, had dyslexia. When he was rejected by the school, prior to the federal legislation mandating that all youth, regardless of their special needs, should receive a free public education, she mobilized her own background as a teacher and framed everything around her core belief. Kids learn best when that learning is based around their own affinities and interests. Horses became the central concept behind every lesson. Reading and math skills were taught using the animals that her son loved. Mrs. Birch was strength-based before that was a topic for discussion. Mrs. Birch's kitchen soon became the classroom for kids from all over the Mid-Atlantic region with special needs. By 1973, she opened the first autism-specific residential education program at the Questover Estate in Berryville, a property that she and her board had purchased for this express purpose. Grafton still operates our residential treatment program on that site today. The headmaster of her school, Bob Steig, grew that program exponentially throughout the 80s and 90s, adding group homes for children with autism and other intellectual disabilities, providing thought leadership to Virginia's early focus on autism, expanding to the Richmond region, and ultimately converting the residential school into a Medicaid-approved psychiatric residential treatment center, which still operates there. After Mr. Steig's retirement in the early 2000s, Grafton continued to develop as an innovator. Examples include our partnership with Virginia's Department of Medical Assistance Services to implement EPSDT-funded group homes in 2008, and partnering with the City of Winchester to operate regional early intervention programming for children birth to age 3 with developmental disabilities, as well as launching our crisis management division, Ukeru, about which I'll go into more detail later in the presentation. Today, we have a staff of approximately 800 individuals representing teachers, therapists, psychiatrists, psychologists, nurse practitioners, occupational therapists, speech therapists, board-certified behavior analysts, music therapists, and direct support professionals. Many others also work with us every day to provide the best framework in which our professionals do what they're dedicated to do. Grafton operates a variety of programs, all within the context of a transdisciplinary treatment team strategy. Everyone on the team, including the consumer and parents, have an equal voice. Our psychiatric residential treatment program in Berryville, Virginia, is a state-of-the-art, hardware-secured treatment facility focusing on children who have not been able to be served in their home communities safely. Our staff are subspecialized in several areas, including the provision of services to children with intellectual disability or autism spectrum disorders, a unit serving young males with sexual reactivity, units focusing on victims of sex trafficking, and others. An accredited school provides a full educational service for these children, including electives, physical education, career and technical training, and horticulture. These services are generally funded by commercial insurance and/or Medicaid, with CSA participation to fund the educational component. Our community-based group homes serve individuals with intellectual, developmental, or autism spectrum disorders, frequently comorbid with psychiatric diagnoses. These are typical single-family homes situated in the community that are staffed in a much richer array than most other Level B group homes. Psychiatrists, nurses, nurse practitioners, BCBAs, RBTs, speech and occupational therapists, they're all available. We also provide a fully accredited school with a career and technical education track at this program site. These services are funded by EPSDT Medicaid services and local CSA dollars. We'll focus more on this in the next slide. We provide applied behavioral analysis within our Grafton residential and educational programs, as well as to our immediate community in a limited fashion. Our applied behavior analysis services are provided with a trauma-informed bent. We are always opting for creating a stimulating and engaging environment in which the child can learn new skills, reinforced by their own affinities. These services are funded by Medicaid or commercial insurances. Our early intervention program provides case management and services to youth from birth to age 3 who have been referred by their pediatrician due to developmental concerns. It is funded by Part B Medicaid. Our therapeutic day schools serve both our residentially placed youth and our communities. They're accredited by Advance Ed and provide a full spectrum of academic services and experiences. The adult group homes and day support services are exclusively funded by Medicaid waiver and provide a supportive community living environment for adults with developmental or intellectual disabilities. We recently partnered with the Department of Behavioral Health and Developmental Services through a grant to enhance our community integration activities to ensure that our consumers are actively and comprehensively connected to the communities in which they live. The Dominion Center for Behavioral Health Services is a fully owned for-profit subsidiary that provides outpatient, individual, group, and family therapy, as well as psychological testing services and psychiatric evaluation and medication management. It is located in South Riding, Virginia, and is exclusively funded through commercial insurances and self-pay. Last year, Grafton was awarded the contract to operate the Loudoun County Youth Shelter and Group Home in Leesburg, Virginia. This is a shelter service and Department of Social Services licensed group home serving youth in need of a safe and secure temporary placement. I'd like to focus on one particular component of our service array, our therapeutic group homes. These services were the innovative result of a close collaboration between Grafton, DMAS, and DBHTS, and over the years have allowed hundreds of children to avoid institutionalized care in state hospitals or acute inpatient services. As an integral component of the overall system of care in Virginia for youth with comorbid developmental and psychiatric disabilities, we initially were deemed Level C, the same level as a psychiatric residential treatment, due to the complex staffing array needed to safely care for our children in a non-institutional milieu. Ultimately, we worked with DMAS stakeholders to develop the EPSDT therapeutic group home level of care within the current residential treatment center manual. Our client population often has medical complications, multiple diagnoses, and families that have been themselves traumatized by lifelong struggles with the service system and the overwhelming needs of their loved ones. We have been extremely focused on ensuring that this service is seen by our stakeholders as rehabilitative, seeking to bring to bear the most impactful multidisciplinary intervention we can in the shortest amount of time. The interface between our service and the localities has been dynamic and is changing. We'll explore this in a subsequent webinar. It was within this service line that Grafton pioneered a crisis management system that does not use restraint or seclusion. As you can see, restraints were frequently used at one point in our history. Understanding that restraints can cause trauma or lead to re-traumatization for clients who have already experienced trauma can damage the therapeutic relationship and can result in physical injury and even death, Grafton has a firm commitment to minimizing and eventually eliminating its use. We no longer employ restraints in our community-based therapeutic group homes. Since implementing this initiative in 2002, we have reduced the use of restraints by more than 98% and eliminated seclusions entirely. And we have done so without compromising either client or staff safety. Although we do use restraints minimally in our residential treatment center where acuity is generally higher, as is the client throughput. Our goal is to eradicate and minimize their use everywhere. We do this by arming staff with a truly trauma-informed alternative. They still have lots of tools, but restraint is not one of them. Using our own experience as a model, Grafton developed Ukeru, which is a Japanese word for receive, the first patent-pending crisis training program offering a physical alternative to restraints and seclusions. It's rooted in the belief that the use of physical restraints is not only unnecessary, but also unproductive, and that all intervention, educational and behavioral, should be built on an approach of comfort versus one of control. Ukeru provides training on these conceptual ideas, such as trauma-informed care and conflict resolution, as well as the physical techniques that minimize the need for restraints and seclusions. Conceptual training is provided on verbal and nonverbal communication, managing and de-escalating conflict by converting or diverting an aggressive client, building an environment focused on comfort rather than on control, taking into account the high prevalence of traumatic experiences in individuals who receive services for developmental, behavioral, and mental health needs. Physical techniques are taught by practicing effective use of protective equipment, such as soft cushion blocking materials, to keep both the caregiver and the client safe. The Ukeru team provides organizational assessments, training, change management support, and capacity building to assist organizations in implementing the model in their own environment. The program has received national and international recognition, including winning the prestigious Negley President's Award for Excellence in Risk Management twice, in 2008 and 2012, the 2013 National Council Impact Awards, and recognition by the Substance Abuse Mental Health Services Administration for clinical best practices in restraint and seclusion reduction in 2010. Ukeru teaches physical techniques by practicing effective use of protective equipment and soft cushion blocking materials to keep both the caregiver and client safe. As Grafton implemented a restraint-free approach, we quickly learned that traditional blocking materials were not effective. While some didn't offer adequate protection, others were physically or visually jarring to clients. We decided that if the tools didn't exist, we would build them ourselves. We developed custom-made soft cushion blocking tools that keep both professionals and those in their care safe and comfortable. In fact, design patents have recently been issued to several of these products, the Flex Shield, the Arm Shield, and the Curve Shield. Today, Ukeru offers the materials to other organizations and trains professionals in their use. Since launching Ukeru, Grafton has decreased client-induced staff injuries, workers' compensation premiums, lost time, modified duty days, and turnover, resulting in an ROI of over $16 million in the past 10 years. Most importantly, the use of Ukeru has been shown to help improve outcomes. Grafton's goal mastery rate was 35% at the beginning of the initiative. It's now over 80%. Ukeru is currently used in 25 states and as far afield as Australia, and in more than 115 private day and residential programs, private and public schools, psychiatric hospitals, and forensic units. We have worked with organizations as large as the California Department of Developmental Services and as small as in individual schools. It is a clear part of Grafton's overarching mission to impact the industry, pushing it towards a truly trauma-informed and strength-based service perspective. Grafton demonstrates its outcomes by using a three-pronged approach. Behaviors of concern are tracked for frequency and severity at all times. Assessments are provided through a battery of well-accepted standardized instruments administered over time. And skill acquisition is assessed at every session, and the impact of those skills on the frequency of the behaviors of concern is assessed using a patented goal mastery process. We believe that a residential service, such as our residential treatment center or our community-based group home, should be used extremely judiciously given the risks that they impose on the client. No matter how good a provider organization is, batch processing children with extreme needs together is convenient from a resource and fiscal perspective, but invites new impacts on the youth. So Grafton strives to keep the length of stay as short as possible. To that end, we guide our clinical teams to inventory at intake the behaviors of concern that preclude a community-based treatment setting. We believe that these represent the most frequent impediments to safe community treatment for our children. Significant psychological impairment is meant to capture psychosis or extreme debilitating anxiety or depression, etc. Grafton staff use the specific evaluations listed above at specific intervals throughout treatment to reveal the child's skill acquisition, the impact of our services on behavioral health problems, and the community challenges that the child is facing. These are preliminary results from the assessment battery we conduct. Regarding the DP3, we can plot their developmental age at intake on average across multiple spheres against where they are currently, demonstrating a gap score, which reveals progress above typical development. These data are available at all times at a client level, as well as aggregated to reflect overall organizational functioning. Grafton has been focused on outcomes data around goal mastery for well over 2 decades. We created our own patented application called Reboot to automate the process for our clinicians. We're currently working to incorporate it into our electronic health record. In short, we ask the clinician to set a baseline for behaviors of concern at the time of intake. We then ask that they express treatment goals in an extremely measurable and observable way, including the time frame in which the goal will be attained. We create a minimum growth line, which simply is a linear expression of the frequency of the behavior between the baseline and the projected end date of the goal. Intervals of that behavior are plotted against the minimum growth line on a weekly basis. If the behavior of concern occurs more frequently for 3 measurement periods than the expected rate on the minimum growth line, we deem that goal not on track and convene the team to plan alternative interventions. At the end of the day, we can express as a percentage the number of goals attained within the time frame originally projected by the clinician. This is our org-wide goal mastery rate. Grafton recently was awarded a patent for this goal mastery process. Grafton is implementing some adjustments to its clinical program of care this year to more clearly demonstrate our adherence to empirically based treatment methodologies. This foundational 5 establishes organizational consistency, and armed with this information presented in an understandable and useful manner, our staff can begin their work with us using a common philosophy that is rooted in empirically based care. Be a Behavior Detective is a reference to antecedent-based interventions. We ask all staff to be actively engaged in answering the why in reference to behaviors of concern. More formally, a functional behavioral assessment can illuminate the factors that are driving the behaviors of concern. By adjusting antecedents, we can affect behavioral expression prior to the presentation of a concern. Assumed trauma is a reference to a universal understanding of the neurocognitive basis of trauma and its impact upon behavior. This generally is mapped to response interruption and redirection in order to intervene in the patterns of behavior that are usually the sequelae of an index trauma or prolonged exposure to traumatic events. Be kind. Numerous studies, such as those conducted by Scott Miller, demonstrate that a primary factor in change is the perception of the relationship between the provider and the client as judged by the client. Children would do well if they could do well. We believe that everyone tries, and repeated failure can make it appear that the child is bad or ill-behaved. In fact, we want our staff to view them as ill-equipped with skills, overwhelmed, or underprepared. Furthermore, this mentality of kindness must extend between team members and to yourself. Teaching refers to our focus on modeling, prompting, and reinforcement. Our staff must view themselves as active teachers of new modes of behavior, especially in response to old triggers. We want them to view themselves as skill builders and guides, not as enforcers or disciplinarians. Using the community as your classroom refers to Grafton's desire to use naturalistic intervention as opposed to synthetic or institutional forms of care. We want the child to practice in their community and school and move them as close to a completely naturalized environment as quickly as possible. We view institutional care as iatrogenic and therefore should be used with the highest impact in the shortest amount of time possible. These are the current evidence-based practices we use as an organization. Our clinical decision support is integrated into our electronic health record and drives treatment planning that is individualized but rooted in established empirically proven methodologies. This leadership team has been together for over 8 years. Jamie is an MBA with an extensive background in behavioral healthcare systems and informatics. Kent is a social worker and MBA with extensive operational experience in behavioral health. Kim has been with this company for over 30 years, moving from direct support to executive vice president and now president of our Ukeru division. I'm a clinical social worker and joined Grafton in 2011 after professional experiences in healthcare risk management, clinical supervision, and as the chief executive of a large residential treatment program in Northern Virginia. We're accredited by CARF, and our educational programs are Advanced Ed certified. We strive to be a partner with all of our key stakeholders, and we count you among them. Please do not hesitate to reach out to me with any questions or concerns. I look forward to partnering with you and to help your organization achieve its goal of ensuring a seamless, effective, and efficient system of care for the citizens of the Commonwealth. We want to innovate with you and together identify the challenges facing the state and provide the right solutions to address them. Thank you for your time with this webinar. I'll be providing another one shortly with some specific information about the unique interface we have with the communities from which our youth are referred. Thank you.